So today we're going to start with a brief overview of the pancreas anatomy and physiology, and from there move into pancreatitis. So the pancreas is an endocrine and an exocrine gland. Endocrine is referring to the fact that it's an organ that secretes a hormone or hormones directly into the bloodstream to regulate cellular activity of certain other organs. The exocrine gland is referring to the fact that it releases secretions directly to another organ or through a duct to an organ. Now, on the endocrine gland portion, the islets of Langerhans produce the endocrine secretion of insulin, glucagon, pancreatic peptides, and somatostatin. These hormones are going to be secreted directly into the capillaries and transported throughout the body to act on other organs. The pancreas is going to also secrete about 20 digestive enzymes or cofactors, and these make up most of the intraluminal digestion or breakdown of the dietary proteins, triglycerides, fats, and carbohydrates, as well as the cleavage of vitamins A and B12. Now, about 80% of the total glandular volume of the pancreas is from the exocrine portion of the organ. So let's talk about enzymes. So some examples of the enzymes the pancreas secretes include amylase. This converts starches into sugars. Lipase. It is a fat-splitting enzyme. Phospholipidase. This converts our phospholipids into fatty acids. Trypsin. Trypsin is responsible for activating chymotrypsin to digest proteins. Then chymotrypsin that is responsible for digesting protein. And bicarbonates, and these are going to be secreted and regulated by the cholecystokinin and secretin that are that are produced in the duodenum and then released into the bloodstream when the food enters the proximal portion of the small intestines. Here's an illustration that reflects how the head of the pancreas is cradled in the duodenum. So here's an illustration that reflects how the hormones that are secreted by the pancreas are released into the bloodstream and how the exocrine enzymes are produced and then secreted into the ducts to be released into the duodenum. So the pancreas is innervated by the parasympathetic nervous system through the vagus nerve, cranial nerve 10, and then sympathetic nerve innervation is through the celiac ganglion and the celiac plexus, with the nerve supply coming from T5 to 6 through T9 to 10 thoracic spinal nerves. Pancreatitis. Pancreatitis is defined as an inflammation of the pancreas. So this condition is going to be diagnosed based on clinical findings, specifically symptoms and signs, and the diagnosis is confirmed by lab and radiographic studies. Pancreatitis is a diagnosis of exclusion, which means that the doctor is going to rule out other differential diagnoses first, and when pancreatitis is the only condition that hasn't been ruled out, then that's what the patient is going to be diagnosed with as their primary diagnosis. So when a patient does present with an acute abdomen, acute pancreatitis should always be considered as one of the differential diagnoses that need to be ruled in or ruled out. Now, another thing to keep in mind is that because the pancreatic enzymes are secreted in excess of what's needed, basically maldigestion symptoms and serious nutritional deficiencies will only show up after over 90% of the pancreas has been diseased or destroyed. So because of this, most pancreatic disease states remain clinically silent or asymptomatic until we've had at least 90% destruction of the organ. And by that point, it's almost too late to save the individual. Also, what we may find is that at times the powerful pancreatic enzymes may inappropriately digest the pancreatic tissue itself that will in turn produce really severe abdominal pain and other pancreatic signs and symptoms. Pancreatitis etiologies. Alcohol abuse is one, and typically gallstone blockage of bile is the second one. Now with the alcohol abuse, it takes only 3.5 ounces of absolute alcohol per day for 2 to 5 years on average to cause the enzymatic proteins within the pancreas to become very viscous and sticky. It changes their consistency, and it will cause them to plug up the small pancreatic ductules, and this leads to pancreatic inflammation or pancreatitis. Now, the majority of the pancreatic damage is going to occur when the activated digestive enzymes are not able to escape the pancreas, and they begin to attack the organ itself and begin to basically digest on the pancreas. Now, there are two forms of pancreatitis: acute pancreatitis and chronic pancreatitis. So acute pancreatitis is the inflammation of the pancreas, and it may sometimes include adjacent tissues, and this is caused by the release of activated pancreatic enzymes, and they're not able to typically escape the pancreas. This condition is reversible both clinically and histologically. So, etiologies of acute pancreatitis. The most common causes are biliary tract diseases and chronic heavy alcohol intake. These two etiologies make up about 80% of the cases, so these are the most common forms. The biliary tract diseases are usually from gallstones that are producing ductal pressure due to distension of the duct. So basically, it's blocking a duct. Other etiologies can include trauma, organ abnormalities, side effects from use of prescription drugs, and then about 15% of cases have unknown etiology. Now, the mechanism of the pancreatitis, regardless of the etiology, what we see is that the enzymes, they are activated within the gland itself. They're going to damage the tissue because they're not able to escape the gland, and it's going to cause inflammation, edema, and it's sometimes severe enough it will produce necrosis. Now, with uncomplicated, mild acute pancreatitis, the pancreas will usually improve on its own over several weeks. Now, with acute pancreatitis, we can have different forms, and they can range from being a mild form with only abdominal pain and vomiting that resolves on its own over time, or a severe form that produces pancreatic necrosis and shock and can lead to multi-organ failure. So symptoms seen with acute pancreatitis include severe pain, and the pain is often described as being steady or boring or knife-like, and it typically is going to develop in the upper abdominal regions, so it may be right upper quadrant, left upper quadrant, or epigastric. 50% of these patients will have pain radiation into the mid-back. It's common to see nausea and vomiting throughout the course of the illness, and eating is going to aggravate the pain. Now think about it. When you have contents moving from the stomach into the duodenum, it's going to have the duodenum distend. It's going to stimulate release of pancreatic enzymes that have been produced, and unfortunately, they can't escape the pancreas, so it's going to cause further inflammation, and inflammation is going to produce pain within that pancreas. So eating aggravates the pain. Coughing, vigorous movement, deep breathing may also accentuate or worsen the patient's pain. Now, when it comes to signs, these patients will often exhibit antalgic positioning. They also appear acutely ill. So as for the antalgic positioning, the patient may lean forward while they're seated. They may stand leaning forward. They may lie in a fetal position to try to reduce the pain. Problem is, it doesn't typically. They will often have profuse sweating. A high pulse will be present on exam, shallow and rapid respiration. The skin may look very pale and may feel cool or clammy. They may run a fever with this. Some of these cases, up to 20%, may develop possible abdominal distension. Possible ascites may develop. And there is usually marked tenderness in the upper abdominal region on palpation. And in some cases, there will be mild tenderness even in the lower abdominal region. Now, with a gallstone pancreatitis, they will typically have a sudden onset of pain, and the pain is going to last for several days until that stone gets dislodged if it can be passed through. With alcoholic pancreatitis, the pain will develop and increase typically over a several-day period, and then it's going to last for several days. So when it comes to diagnosis of pancreatitis, remember, this is going to be suspected whenever there's severe abdominal pain that occurs, especially if the patient has a significant history of alcohol use. It's necessary to rule out other differential diagnoses like perforated ulcers, strangulating intestinal obstructions, dissecting abdominal aortic aneurysm, appendicitis, diverticulitis, and myocardial infarction. Remember, these other items are going to have to be ruled out first, then they would diagnose with the pancreatitis. So the definitive diagnosis is made through imaging and lab tests. Imaging includes abdominal x-rays as well as CT and MRI. Lab tests are going to be serum amylase and lipase. Now these lab findings, they are going to increase the first day to like 3 times the upper limits of normal. The problem is they return back to normal levels within 3 to 7 days. So if the person doesn't come in within the first few days of that pain presentation, we may not find those lab findings. Also, the elevated lipase tends to be more specific for the pancreatitis diagnosis. The treatment for pancreatitis is bed rest, increase fluids, and then provide the patient pain meds. A couple of additional items. Recurrences of pancreatitis are common because the patient refuses to change their lifestyle. Keep in mind, we're looking at the fact that alcoholic pancreatitis is one of the 2 most common etiologies for this. Also, up to 10% of these patients will die within the first 2 weeks due to cardiovascular instability. They develop shock and renal failure. If we suspect this on a patient, our case management is we need to refer them out to an ER. They need to be immediately evaluated.